Brindley and I wanted to kind of start out the interview and conversation because as many people know, I've been an HS advocate and patient advocate for 30 years. I just had a birthday, 30 years. And I've had HS and severe HS 43 years now. And surgery has, even though it has not been 100% successful in all areas and every aspect, it's been very rough on me. It has probably been the only answer for me. And I know Brindley can share some of her story, but I definitely want to share my aspect of it. And this is coming from someone who's very ill with other illnesses. It's not easy. It's hard. It's a very personal decision. But what we struggle with, Dr. Goldberg, is, first of all, there's not enough surgeons out there for HS. I think we all can agree. The second part of it is, even with surgeons that are interested or even are educated with HS, they're turning too many people away because they're too severe. No. That is, I'm probably one of the most severe cases, and many like me, and we are the perfect candidates for this, even if it's not all in one shot. Now, I've had several areas, especially on my upper thighs and inner thighs, all the way down to my knee, where my surgeon had to go 3 or 4 rounds with me because it couldn't be done all at once. And that's okay. So we wanted to bring you back because we've done a series with you, which was amazing, by the way. Thank you. But we wanted to bring you back again to say, hey, how can we educate more clinicians and surgeons to, I don't know, help build that confidence? Because I think that's a lot of it. They're just not confident enough that they can help these people. Sure. And don't turn away the most severe cases.
So thank you for having me. I'm really excited to be here. And as you all know, I'm very passionate about my work with HS patients or people with HS. It's truly been one of the, I think, the most rewarding part of my career. And it's hard. It's hard for patients. It's hard for surgeons and providers. And part of the reason I got into this field was because I didn't feel HS patients were getting what they needed from surgeons. And I didn't feel that we knew what to do for them and how to do the right thing. And obviously over the course of 10 years, I've become much more confident about my abilities to help. And I'm going to start by saying that everyone is a candidate for surgery. Everyone is a surgical candidate. And I obviously operate on HS patients a lot, in addition to other patients. And just this past week, I walked into a room with a patient of mine who's, she's been my patient for about 5 or 6 years. She's no longer a teen. And I said, are you excited? And that's how I want you to feel about surgery. Let's get excited about surgery. And I know I might be different than some of the other providers, but I know where I can help you, where I can't help you. I've fortunately gotten the ability to anticipate where I can make things worse. And I know when to stop or when to not even embark on this journey. And the other piece of it is what I really focus on with patients is what my goals are, what my goals are, and that came out wrong, and what their goals are. Okay. So what is our goal of this treatment plan? And I treat every patient differently. So if there's one thing that you can do to advocate for yourself, it's to go into a surgeon with a goal in mind. Most of the patients who are watching this today are very well educated about HS, and you are ahead of the game. It's amazing. And I can gauge with patients when they come into me, what level they are in their understanding of the disease and where they are in the course of dealing with the significant lifestyle of the impact and the effects of this on their life. So the most sophisticated patient, the most educated patient with HS will come into me and say, these are my goals for surgery. Okay. Or this is why I'm here. And if I don't get that, if I get the sense that the patient does not understand that, I'll actually guide the discussion by saying, what if you had one goal today, what is it? Or what is your goal of surgical treatment? And then we take the discussion in whatever direction it goes. So I would get tidbit number 1 is absolutely know your goal when you go in. if you go in to see, and that's going to make the surgeon less scared. So even if they're not as educated in it, what it's going to do is it's going to create trust. You know, it's important for people who are affected with HS to trust their physicians. It's also really important for physicians to trust their patients, especially surgeons. We don't want to embark on a doctor-patient relationship with someone who has unreasonable expectations, and the nurses and the staff don't want to do it either. And living with HS is very challenging. Taking care of patients with HS, as we all know, is also challenging because it's not a one quick fix and you're gone. For the most part, it's a long-term relationship that you embark on with a lot of uncertainty, a lot of doubt, and not being able to predict the course. And truthfully, that's what I enjoy about it, right? About the relationship. But I can definitely see for other providers how daunting that would be, and how and why they put up that wall. Okay, so I caution you as a person with HS to go and looking for a cure. Okay. I selectively use that term with patients, and I selectively use that term with patients in the context of if they have very focal disease that I might be able to, for this moment in time, get rid of that for them. Otherwise, I'm talking about quality of life. And even those patients, those very select patients that I use the term cure for, I caution them that this is a systemic illness. There may be additional recurrences. There may be disease that develops in other places. But this is what we have to offer you right now. And I do turn away patients. It's rare that I can't do something to help a patient in some way. It's just understanding what our goal is.
That's amazing. That's amazing. And I also spoke to Brindley. I have an amazing plastic surgeon. Amazing. I'm so blessed. I've been working with him for 5 years. How long we're still working on my HS. However, I have HS on my entire back. He won't do it. Even though he initially promised, let's hold off, we'll do that last, because it's such a challenge. Now that I have come back to him, I believe, Brindley, what it was a year ago, I've come back to him. Okay, we're ready. We've done all my other areas. My back is probably one of the worst as far as my quality of life and being able to sleep and trying to dress it, everything in between. And he had decided that it was too much of a challenge for him to take on. I'm still mourning that, and that was last year.
So, there's very different approaches, and it's very hard because for the providers, because there's a number of different providers with different backgrounds who care for this surgically, right? Some dermatologists do small procedures. You have plastic surgeons who work on this, who are often focused on more of the reconstruction effect of everything. And what we know now is that some of those reconstruction can actually make disease worse, especially if it recurs. And then you have general surgeons, and the traditional mantra and teaching for HS surgery is cut it out. It's cut it out. That's it. But we now know that there's other things that we can do. So, and you can edit out this part if you don't want to, but I'm gonna use you as an example. Okay.
Please do.
So what I would do if you came to see me is I'd say, what's bothering you? And you already told me you're having trouble sleeping. And I'm not going to make you go into more detail than that, but what we would look at is, are there certain areas of your body that are bothering you more than others? Are there areas that are continually chronically inflamed, no matter what you do, that drain, that causes, because you know what, we can help you. We can't cut out all the skin on your back and give you all new skin. And I don't think you really want that. But I think what you want to be able to do is have wounds that aren't flaring as much so that you can sleep on your back or your side and be more comfortable. And
get a hug. And get a hug.
And get a hug. And I guarantee you that's something that we can do for you.
Yep. I know. If I could come to you, I would, in a heartbeat. Oh, believe me.
And that being said, I'm happy to talk to your plastic surgeon.
Okay.
If that's something and I'm happy to talk to anyone truthfully who will listen.
No. this is good to have. This is the kind of talks we need to have, because again, even though I love him, our bond is so close. I feel like he gave up on me, and
And
that I'm mourning that loss. And then I'm thinking, and I've talked to Brindley that I would love to come see you if I could, because you're quite far away from me. And, you know, let our members know that they have these options,
yeah.
right?
Absolutely. And I do have people who come from all over to see me. And I do a lot of virtual visits and things like that. And this is not an advertisement for me. Okay. I'm also, I'm a trauma and general surgeon, but I want to help you get the care that you need. And let me give you an example. Actually, there was a nonprofit in the area that's actually geared more towards children. And one of the plastic surgeons in the area, who's an excellent plastic surgeon, had a patient in another country with that she had operated on for other reasons many years ago with HS, and nobody knew what to do down there. It was just too much. So we did, and she got my name because she had heard that, you know, I'm in the area and I do a lot of this. And we had a virtual visit and had discussions with the family. And then this nonprofit actually brought the teen up to this area, and she operated on him. And I went there and I helped her, you know, and guided her on what to do. So I think the biggest barrier for people with HS is finding a surgeon who is willing to take this on. Okay. And willing to think out of the box, and willing to, if they don't know what to do, to figure out what they do. I'll tell you my first case of this, that where I realized, you know, you always think that the surgeons older than you, who are more experienced, know more than you and know what they're doing. And the answer is they don't always. But when I was junior faculty, my first job was where I trained. And my senior partners, who I revered, passed along some cases to me. And I took an HS case to the operating room, and the HS case was in the groin area. And I said, well, what do I do? And she said, well, just cut it out. And I said, okay. And then I'm thinking, well, I'd done it in the armpits before. We have a standard procedure that they called the Pollock procedure. You cut it out, you close it. It's old dogma, which I don't follow anymore, by the way. And I do excisions for some patients and deroofings for others, and combinations of both. But I learned from the dermatologist about 6 years ago, do not close these wounds, or maybe partial closure, but closing them just makes matters even worse. So I'm in the groin area and I'm operating and I'm cutting, and I'm like, this is deep. So I get her on the phone while I'm in the operating room, and I said, this is deep. And she goes, it only goes down to the dermis, cut it out. And that's when I saw all the significant scarring. And that's when I realized that actually the scarring can go deeper, and this can lead to significant disfigurement. And it was at that point, when I started having more and more patients coming to me, that I was fortunate to be able to find the HS Foundation and learn from them. So I think it's just a matter of finding the right surgeon. If you go see a surgeon and the surgeon immediately says no, it's either time.
I'm sorry, guys, my battery's dying. Just keep
Oh,
talking.
that's okay. Do you want me to keep talking?
Yes, please.
Are you sure? Okay. So if your surgeon immediately says no, or is not interested, or doesn't want to see you, it's probably not a good fit. If you can find a surgeon who's willing to educate themselves or work with you to help understand, then it's a good fit. And, you know, again, everyone has a different all patients have different understandings of what HS is, and some are more sophisticated with others, not in a bad way. It's the information that's been accessible to them, right? To be able to become educated about it. But the fit is very, very important, because it is scary. And so that's my tidbit number one. You know, I gave you tidbit number one. Tidbit number two is, and I'm making this up on the fly, is not everything needs to be a major operation. And what I have learned over the years is some patients, it's too much. You know, we have to establish that level of trust. Everybody is different. You know, when you, this is just coming to me for what it's worth, but say you have to cross a stream, okay? Some of us will just walk into the stream. Some of us will pause and look at all the details and try to understand, what is the risk from going across the stream? And do I want to go across the stream? And do I not want to? And some of us will just kind of, like get a little information. And then when they feel a little trusting, go for it. Well, maybe there's a rock in the middle of the stream and you don't have to cross it all at once. And I hope that's a good analogy. But if I have patients who I even think that they don't have a sound understanding of the process, and I don't expect them to, but if it's something that's too much for them, we start small. And what I find is, and there are patients with severe, and forgive me, I'm trying to get in the habit of saying person with HS, but when I talk about this I naturally go to patients. So I hope I'm not being offensive in any way.
No, not at all.
Okay. So with people living with HS, it's scary. And what I typically find is there's some patients who come to me, they're so severe, and we have to say, you know what, we are going to intervene, and we don't have that luxury of doing a little here, a little there. But there's others where we have time. And it's going to be a process. And let's start. And typically after the first procedure, they're like, oh, I got this. I can do this. Yep. And then it makes each procedure, each touch up, each additional area that we address that much less scary. And there's a lot of hand holding that comes into play, not in a bad way, not in an accepted way, right? With these different procedures. And it's a personal decision. So I have a patient who came to me recently with severe HS in multiple different areas. And he said, I want it all done now. And I said, that's a lot. That's a lot. And, he said, I said, your arms are going to be out of commission. Your groins are, both groins. I think it's just too much. And he said, you know what? I know me. This is what I want to do. And I just want to get it done with once. And I actually felt like he could do it. He could handle it. And I set expectations, and it hasn't been without its challenges psychologically, but it's doable. I have others where we say, you know what, let's hit the pause button, or I might bring them back multiple times and educate them. So go in with reasonable expectations. And if you don't feel that you and the surgeon are on the same page, there's someone else.
That was one of the questions, is how do you deal with, because you have, in looking at it from the outside, and when you're doing a consult, you don't know what you're going to necessarily find until you're actually in there.
And you mean in the operating room?
Yeah.
I do tell patients that, and that's an important piece to actually educate surgeons about as well. Okay. Is that I kind of have a game plan going in, but truthfully, and if I operate on you the next day, I have a real good game plan. But even if it's a couple of weeks, the nature of this disease, things can change in a heartbeat. And oftentimes I don't know what's beneath until I see it. And what I try to do is I try to say, so when you go in to meet with your surgeon, it's like an elevator talk, right? If you're on a job interview, you need to tell them who you are, what you do, what responsibilities you have, so that they understand your life and what your goals are. And if they can match those things, then that's great. And if they can't, wrong fit. But what I often get to a point with, and most of my patients I have operated on multiple times for various different, not a bad thing, just we plan this. They might have small kids at home and may not have, or may have a job where they can't. Like I have a lady who, I know she won't mind me talking about her, but she was actually the first one that I embarked on more significant de-roofings. I had learned them from the dermatologist. And I said, I think you're a great candidate. I've never done this before, but, let's try it. And she was game for it. She did not have the luxury of not working. She didn't have time off. She didn't have short-term disability. So I said to her, okay, let's try the first one. Let's see how it goes. So we started small in the groin area, and it was healing well. And she's like, all right. So I said, okay, I think I need about 5 small procedures with you, 5 20, 25-minute procedures. We're going to do them in the operating room. I think it's going to take about a year, give or take. And sure enough, it was about 14, 15 months. And it's great. And she didn't have to give up her life. So that being said, another pearl, if you will, is when you go in there, it's hard. It's really hard, but don't be the victim, be the advocate. Okay. Because if you are the victim, the physicians and the providers are going to sense fear. And fear is something that is very real, but it's going to turn them off before you can even establish that relationship. So, and lay it out with them. I don't expect a cure. And maybe you haven't done this before. Everybody has the ability to do these procedures. I hate to demean what I do, and that's not my intent, but what I'm doing is not rocket science. Any trained surgeon is very capable of doing this. They just have to show the interest and be willing to take the patience and the time to do it.
It's funny, I actually have been bugging my general surgeon because he's reaching out to the education department at University of Washington, because I'm like, I need to get in front of your residents. I need to tell them what an impact you have on people's lives and why they should want to do these procedures. Like, we need more people like you and like Dr. Kim who understand the impact that it has. And for a surgeon, I think, you guys, a lot of times, especially general surgery, are like one and done. You never see people again. So repeat customers like us can sometimes be seen as like, oh God, why are they back? But we're actually back because it's a good thing, because it worked for us, that we want to undergo it again. So it's an interesting dynamic, because it's not the repeat patient. Like a derm is used to seeing us multiple times, but I think, in talking to Dr. Kim, he was like, oh, you're back. It must have worked. So that was really nice. And we definitely need more surgeons who are well-trained in doing this, and who understand the nuances. And like you said, can take it piece by piece if that's what's necessary, but can also help make that determination. Hey, you want to do this all at once and you feel good about it as a surgeon, then, you can go ahead and make that decision. So.
Oh, and a point I wanted to make before is when you were talking about, you don't know what you're going to find till you go in there. Oftentimes what I say is, we're going to start. And at some point, I'm going to plan to do all of this, but there's a point at which I might say, you know what, this is too much. We got to stop. And it's typically a gestalt, it's a feeling, and it depends on the person. And I actually say, I need you to trust me on this. And most of the time they do. So that's not an issue. But you're right. You don't know what you're going to find. And there's not, with HS surgery, there's not one technique or one procedure that you use. I do a lot of complex de-roofings right now. And I've gotten to the point with and I've had good outcomes. So my technique, for what it's worth, works. And I think there is a little operator dependency, but I can kind of tell when there's a little microscopic or tiny tunnel coming off of a big tunnel. And I may not be able to stick a probe in it, but I'm like, you know what? These two areas, they have to connect. And if I don't do something in the area in between, even though it looks normal, it's going to be a problem down the line. So but the more and more you do this, the more sophisticated you get with doing it. And it's practice, right? It's practice. So that being said, a lot of surgeons think of it as only excisions. And I won't lie, in the surgical world, you don't get a lot of credibility as a surgeon doing HS surgery. It's just, which is hard. It's hard for me as a surgeon to justify to my partners are great people. They're amazing. And but they don't necessarily they can do a lot of this, but meanwhile I have all these patients coming. And it's kind of like, oh, Goldberg's HS patients. So it's very hard as a surgeon to even get going in this field or want to get going in this field. It's, these are not sexy operations in the surgical world. So if you can find the right person to take you on, you've done good. But that's why it's been so hard to engage other surgeons in doing this. They're just not that interested.
If I can spin off that real quick, my surgeon, again, plastic surgeon, but his specialty is burn patients.
Mm-hmm.
So he has repeatedly have told me, even though he has been doing HS surgery since 2008 or something like that. And again, they just kind of fell in his lap. But once a surgeon is found, guess what? We all flock to them, right? So where I'm going with this is, he has stressed to me numerous times, because I've had over 32 wide excisions, and a couple of them I've been in the hospital for a month stint, because just very, very intense. And anybody watching this, I'm not a normal case.
Not everybody needs to do that. You don't, it's all, everybody's different.
Don't let that discourage you. But especially for my breasts, we had to do 5. I was in the hospital, drain tubes. It was very intense. But my point is, he has stressed me when I said, why, when I come back to you again, are you getting more and more hesitant? He said, Denise, I got in this to help burn patients and to repair their skin, to make them look better, to give them better quality of life. He goes, HS for me, I am disfiguring you. I am mutilating you. I'm causing you pain. That's his mentality. Mm-hmm. Now, even though he does this and he helps hundreds of us, he has that mentality in his brain that I don't think's ever going to go away. And that might be true for all plastic surgeons, right? Not so much maybe general surgeon, but plastic surgeons, because they want to fix and make you look pretty, or make you look better, I should say. How do you feel about that?
I think there's something to that. I think it's perspective. You also have the situation too of the group of people who in theory would be the best people to take this on would probably be wound care doctors, but wound care doctors aren't surgical for the most part, or they're surgeons who they don't do surgery beyond and that's not true of everyone. That's not, so that's not a global statement, but I think you're right. I think, and that's where I go back to the goals of care. I think framing the goals of care, and, if there's one thing that the advocacy groups could do, it's put together a sheet of paper that they can fill out, people can fill out, and they can take to their surgeon, and they can say, look, this is my life. This is what I want. This is what I need. And truthfully, we could frame it off of not that I'm perfect, and I'm far from perfect, but we could frame it off some of the things that I use to when I interview my patients to find out, or to get a game plan as far as what I think the best thing to do is. And, people have different needs, right? People have different maturity levels in their psychological thinking, sometimes because of age, sometimes just because of development, and people are just different. So I think all of those things need to be taken into account. In terms of the disfigurement, I don't think that way. And I don't think that way because I'm not thinking you're right. Plastic surgeons, their goal is to make them look pretty or high or in multiple different areas of the body, right? My goal is to give them relief from whatever it is. So, and in all fairness, I do talk about cosmetic disfigurement especially in the groin and the pubic area, especially in my young women, right? My young men, for some reason, my young men don't tend to think that way when they come in, especially a lot of times they'll, inguinal disease or scrotal disease. My young women, it's a whole nother story. And the first thing I tell them is, you're going to look good. You're going to look good. In fact, my last patient said, oh my gosh, I have a pretty vagina. We're going to get you better than you are right now. And one thing we know about HS is that HS patients heal really well. And I'm not talking about healing from flares. I'm talking about healing from us de-roofing, taking out the tunnel or getting rid of all that inflammatory gunk, as I call it, or the jelly down below. But they heal really well. And it takes about a year, but scars heal really, really well. So you're going to look great and you're not going to be in pain. And I encourage my patients to wear this as a badge of honor. And most of them do.
We do. Brindley and I talk about this often, and I've explained this to other surgeons, to include my own, but it comes back. And like when I've gone back to visit, he goes, but it's coming back in this area. And I said, stop. I need you to stop right now, because you took me from a very severe stage 3. You took it away for a moment. First of all, I don't care if it's 6 months. Matter of fact, my arms, I'm going on 4 months or 4 years. Oh my gosh, knock on wood. Other areas, not so much, but that's okay, because you want to know why? It was so severe. And he took me down to 2 stages. So even if it's coming back, it's coming back as a stage 1, as if I was in my 20s again. That is a celebration.
The way it comes back. So I'm going to digress a little and talk about the different types of surgeries so that you can help set expectations. So incision and drainage, it relieves a lot of pressure and pain. Not a fan if I'm, in my mind, and I'll tell you why it makes matters worse. And I see this all the time from other surgeons or emergency room, is it's going to come back. Now you have a separate incision on top of an area that already was probably a formed tunnel. And now it just spreads. You just have more disease and a bigger wound to contend with. And it just makes it much, much difficult. By the same reason, this isn't true all the time, but if you close a wound in an area where there's a high likelihood that there's more surrounding disease, or if it's in an area that could develop surrounding disease, when it recurs, and it's going to recur along that incision line. So you also now have a much harder surgical wound to deal with. And now all of the planes from before, from when you just had your tunnels, are scarred, and it makes it much harder to find anything. One thing though to remember with some of these, so let's say I do a de-roofing, okay? And my de-roofings are a little different than some of your run-of-the-mill ones that are done in the dermatology office, just because I have more resources available to me and I can do bigger areas. So we're not talking about one little tunnel, but for the most part, if it does recur, it's recurring much more superficially and much smaller. So I call that a cleanup procedure. And the terminology that I'm using for this, I've actually stolen from my work doing colorectal, okay? So many of you will be familiar with the concept of an anal fistula. Anal fistulas are not HS, but they are very common in patients who have HS, and they're a pain in the butt regardless of whether you have HS or not. And the recurrence rates are incredibly, incredibly high. And there's different techniques you can do. And the trick is to avoid any long-term issues with sphincters and your ability to control your stools or things like that. So less is more. But even if the first operation doesn't quote unquote work, or it comes back, most of the time it's so superficial this time that it's so much smaller and so much more easier to manage. And that typically takes care of it.
Yeah, I 100% agree with you. Everything you just said.
Yeah, so that's my philosophy when I've really applied that towards HS now.
Good. Brindley, did you have anything else with our kind of attacking her on both ends? I know Brindley's had amazing experience with her surgeries as well. But gosh, I think she's covered just about everything as far as.
I think the only other question that we had was about the, we hear this constantly as well in the community, is if you have surgery, it's just going to move to another location. So how does that work?
We don't believe it moves.
It doesn't move. I've taken different approaches to trying to respond to this question, and to say it's evolved, and it also depends also on the person. But what I try to impart on them is that HS is a systemic illness. It's a systemic chronic disease, as hard as that is to hear. So unfortunately, you're at risk of developing it anywhere, right? Or any in the traditional areas. And we've seen it in plenty of areas, which are not traditional either. So there's a couple of different ways to look at it. There's a local recurrence in that area, and then it's moving to another area. And in their minds, it took me a while to understand this, but in people's minds, it does make sense. It moves, it jumps from here to here. It's going back to that goals of care. This can happen in so many different areas. And truthfully, the stress of surgery, we know stress has a big impact, right, on autoinflammatory and autoimmune disease. Surgery is stressful. And I'm not talking about psychological stress. I'm talking about stress on the body. Undergoing anesthesia, doing all those things, you're setting off all kinds of different inflammatory cascades or actually I'm speaking out of turn because I don't know the specifics of that, but I'm going to assume that it's very, very stressful on your body physiologically. So I've also seen patients who flared a couple of weeks later in an area in that same vicinity. And I'm sure they're related. And that's why the medical management is so important. Medical management in combination with surgical management. Now, there's some exceptions to that, okay? And there's some, because there's some patients who come in who don't have dermatologists, and I am not as eager to get them in with a dermatologist. And I may actually say to them, I don't think I think we can take care of this surgically right now. And I think you don't really need any medical management right now. And if you develop any issues, then let's go ahead and do it. But in the meantime, let's not challenge your body with changes in microbiome for the antibiotics. Let's not put you on the biologics if you don't need to be there now. And I actually have a gentleman who I saw the other day who, one of my dear patients from many years, referred to me, and shout out to her if she's hearing this. And he came in and he had many surgeries in the past, and he's done very well for many years. He's had this disease for 50 years, and he's currently not on any medications. And I said, you know what? Don't. I don't think you need to be on them right now. And let's get you through the surgery. Let's see how it goes. But everything is so chronic and focal. I think your inflammation, like just pulling out all that stuff, is going to make your inflammation levels go down to a point that I don't think you're going to need it. So, and by the same token, there's some patients that I say, all right, we got to get you in with medical management before this, because that's going to help make my ability to operate that much better and give you a successful outcome.
That's amazing. And I agree again with everything you just said.
And then the only other pearl I think is that comes to mind is, we've caring, the surgery is the easy part. Okay. I love being in the operating room, and I can walk out of an operating room, especially with HS, feeling like I did something right and I did something well. It's when you go home and you have to heal. That's the hard part. And it's hard on patients. It's even harder on family members. So what I'm going to ask, and this isn't directed, if any of my patients are watching this, this is not directed to any of the patients or family members. Be kind with the staff. You're freaking out. You're, not sure what to do. This is completely new, uncharted territory. But when you talk to the staff in the office, they're overwhelmed too. So enter it with a sense of kindness and journey and doing it together, because they're often the frontline people to getting to us as well. And a lot of times what you need is a little reassurance, but the kindness goes a long way.
Thank you for saying that. That
Yeah.
is important, right, Brindley?
Yes, I would totally agree. And do you typically send your patients to wound care if they've had wide excisions, or?
No.
Okay.
What I do is I arrange for home health and home health wound care to come out. People don't really need it. Okay. What I mean by that is that the way I do it, you can't screw it up. Okay. And I tell them that this looks scary, but it's going to be okay. It's like putting a piece of gray felt in a wound. Once you strip back the dressings, once you get over the shock, right? There's different stages. It's like the stages of grief. There's the stages of adapting to holy, like, oh, I'm excited, this is going to be awesome. And then it's peeling back the dressing and be like, holy crap, what did she do?
Yeah, there's a piece of T-bone steak in my arm. Yeah, in my armpit. Yes.
She's disfigured me. I'm never going to heal from this. It's uncomfortable. How will I get back to life? What did she do? And I get that. And then you get to the trust and they're like, oh, this is healing. So I actually don't see patients back for about 3 weeks. Okay. And even then, I truthfully have patients who come from all over, and a lot of them are in school or have jobs that, that they can't take the time off. And I'm going to, for the most part, now that I have my system down, I'm going to look at your wound. I'm going to say, that looks great. Bye. So I have patients send me pictures through the portal every 3 to 4 weeks. And what I say is, keep doing what you're doing. Come in and see me. And actually, some of the less sophisticated cameras often create cause for coming in, and then they come in, you're like, wow, this looks really good. I don't know why it looked that way on the picture.
False alarm,
or change up what you're doing. So it's one of those three things. And I can get you in right away if I need to see you. Those first 3 weeks are very hard for people. And that's typically when I got a lot of the phone calls with the, and like I said, if you need to come in and see me before, come in and see me or send me a picture. And we'll, sometimes it's just a lot of reassurance. But what often comes out over the phone, especially to the nurses or the front desk staff, is anger.
Which I think comes from fear as from a patient perspective. But yes, we have to be very conscientious of the fact that, they don't know what's going on your end. You can't expect them to understand that. You have to, warm them up, tell them what's going on. They're there to help you. They're not going to hang up on you unless you're rude to them. So they're going to, help you get to the person who can help you best. So yeah.
They absolutely are. And actually, it would be really interesting for you to do a sit down with some of the nurses and the front desk staff to kind of get their perspective. And I'm happy to talk to mine and see if they're willing to do it.
That would be amazing, because I definitely think our community needs some help in that.
They do. Yeah. And because otherwise what happens is, since they're the front line, it's kind of like they become this punching bag.
Mm-hmm.
Yeah. And it's not intentional. Like you said, it's out of fear. And, if you're going to let someone operate on you, you have to trust them. If you don't trust them, walk away. And it's not that they're not good enough. It's that you have to have that ability to say, all right, they got me. And you treat them with that trust, and you treat them. And the same thing for a surgeon. I turn away patients. It's not that I'm discriminating. It's not that but they may not be ready.
Mm-hmm.
Fit. I think you have to have the right fit all the way around.
Right. And that's okay. That's not a bad thing, because it is a partnership, and it has to be built on trust. And the truth is, trust is something that comes over time. Right. So then you say, well, how can you just walk into an office and know to trust someone? You can't. But the truth is, when you make the decision to do surgery, you're kind of taking a leap of faith, and you have a gestalt, because you've learned in your life who to trust and who not to trust. And if it just doesn't feel right, I don't want to operate on you if you feel uncomfortable with me. Even if I'm the best surgeon in the world, and I guarantee you, and you have a trained surgeon out there, they should be a good surgeon. There's thousands of good surgeons out there. It's not just one person. So that's why I think it's more about building that relationship. The challenge, though, if you get angry and get upset, there's always a solution, right? That's there's always a solution, as I say, all wounds heal to some extent, or heal. But how you approach the front desk staff and the nurses, they're part of your care team. And what that may do, instead of engaging them, is actually push them away. And then really difficult situation. So don't do that to yourself, because they're an important part of your care team.
Well, and by proxy, if you're choosing to trust your surgeon, then you're choosing to trust the people your surgeon employs as well as part of that team. So that's the way I look at it, is it's like they're an extension of you. So if I'm choosing to trust my care to you, then you've chosen your team selectively to help with my care as well.
Yeah.
So yeah, it definitely makes a huge difference. And those people, they don't deserve it. They're just trying to do their job and help people.
They are. And, you know, the difference, and this is another thing that goes to talking about surgeons' interest in HS. Typically, you're right. It's a one and done type of thing. So there really isn't a lot of interface on the backside of things. With HS patients, a lot of nurses and staff are not used to caring for having these patients calling, asking questions. I'm actually working right now with my staff, with the nurses and the staff in the office to come up with some better documents that might answer a lot of the questions up front, because it does put a strain on, you know, on everybody. And that way everybody can be empowered in so many different levels and advised and feel more comfortable. So that for those patients who need to know what the journey looks like and how they're going to cross the river, they have that information in front of them.
Yeah. And I think some of that does make a difference. Like I went to wound care once a week because I felt like it was important, and I could actually learned that in a support group after having surgery originally. Someone was like, go to wound care regardless. And it worked really, really well for me. One of the things that I liked about it was that A, there were products I had no idea even existed. And B, hearing how much, not like I had a bunch to do with it, but feeling like I had healed that much each week and watching that come together and hearing the measurements, I was like, I'm doing a really good job. Even though
that's interesting, because I tell patients your wound is going to look like dog meat afterwards. Okay. You're going to be mortified. You're going to be scared. You're going to be mortified. And you're going to say, what the hell did she do? It takes about 3 weeks to really see any kind of change. Okay. And then after 3 weeks, and that's why I say, I don't want to see pictures for 3 weeks, because I won't be able to gauge how it's doing. When I look at it, it actually, I say, oh,
Hamburg. Ground up hamburger.
A lot of times I cauterize a lot of things. It looks, I can't tell whether it's dead stuff or not, you know, and it frightens me, quite frankly. But then after every 3 weeks, you know, once it kind of kickstarts, it feels from the bottom and then it just starts closing in. And sometimes wound stalls, and
it does. And we have some tips on that too. We want to talk to you when this interview is done. So when we're done, we'll pause. I have a few things I need to say to you.
Sure thing.
It's going to help you as well.
Wonderful.
Yeah, I think you're totally right about the initial shock piece, because that is 100% the truth. And it's like, you let people walk out of here like this, you know, when you get home at first and after you're seeing it, it's like, wait a minute, are you sure that I'm okay to not be in the hospital? But then watching your body heal is the most miraculous thing. And I would implore people to take pictures every week of how that happens, what it looks like. I mean, how it goes from, you know, a huge chunk out of your armpit to like this tiny little baby scar that it was like, how did that end up like that? I mean, it's absolutely the most fascinating thing.
And what I like to do is I like to take pictures in the operating room and then show it to the family members / caregivers.
Yes.
You know, of course, respectable pictures that are protected on the chart, but so that they can get over that initial shock with me there.
Yes.
It's a little less scary if I say, you know what, this is all right. This is going to be okay.
And I totally agree with that, actually, because my mom has been my caregiver after I've had surgeries. My husband is very squeamish, so he comes in at the very end where I can't talk to him while he's doing bandage changes. But I had a really deep wound on my abdomen, and she had to, you know, put a little wet to dry in there, and she made the most hilarious laugh. It was like the most nervous laughter I've ever heard, and she was putting it the wet to dry in there. And I think it does come as a huge shock to whoever's going to be helping you as well. And especially, you know, armpits and groins are so difficult to bandage by yourself.
They're very difficult to
You
manage.
can't at first.
And that's why I really try to emphasize wounds are superficial. What I try to explain to them is you really can't screw it up. We might have to change things up or tweak things a little, but you're not going to hurt anything.
Yeah. Also, I want to, Brindley and we're so different as far as like she goes to wound care that works wonderful for her and others. I do the in-home nurse care. Mm-hmm. Again, my husband, he will faint if I even show him. You can't even look at the pictures.
That's okay. That's all right.
Yeah. So I have no choice but to do the in-home care. And, some of my areas have literally been like this.
Yeah.
That works perfect for me. I never needed wound care. I have a certain protocol that I follow myself. I'll talk to you about that offline.
Sure.
But, so it really depends, but we really want to make sure we know to advocate and help them know to at least ask for the in-home nursing care to see if their insurance covers that, because some people have have kids and they can't, and the spouse works and they don't have that family dynamic where they can have the loved one always, helping.
Mm-hmm. And for most home, I have found, and everybody has a system that works for them, right? So I've kind of figured out what works for the kind of wounds I do and how I do it. And I do want daily wound care changes. I do see a difference in the healing and the biofilm and so forth, despite what manufacturer recommendations might say and so forth. But the truth is most home health will not come out every day.
Yep.
So what I like home health to do, for the most part, is teach you how to do it so that you're not scared.
And I know how. It's just having that person come. And again, with COVID, they won't come every day, especially, but they at least come enough a week to assess, take your vitals, make sure it is coming along okay, especially the areas we can't see ourselves, right? I can wound things on the back of my butt. You would be surprised what I can do, but I can't only see, is it progressing? How's it looking?
Very true.
That's what they're helpful for.
That's a very, very good point. Yeah.
So,
yeah.
Well, did we have any other questions? I mean, she went above and beyond today. Thank you.
You brought your A game.
I apologize for talking too much. And
no, it's fascinating. We could do this for hours.
Well, and my intent, and I realize now my intent by talking about the nurses and the nursing staff was just more talk about how to engage members of your team, because it is a lot. And most of your nurses and front staff or even surgery schedules they're not used to working with this either, in the same way that surgeons aren't. So it's a piece that I think I have not fully appreciated before. So I've been spending a lot of time thinking on how I can facilitate and make it easier for them as well.
Yes, and we would be absolutely happy to help get the word out to people about, and I think some of it just comes from not knowing how to deal with those situations, if people haven't had to deal with that before. So I think we can definitely do some education and help on our end with that.
Yes.
Wonderful.
So, thank you so much, Dr. Goldberg. I appreciate it. It's been awesome. All the information you impart on us, as per usual, will be put to good use. So thank you so much.
It's an honor.
Don't go anywhere yet.
I really enjoyed it. Anytime.
Thanks.
Thank you.